I'm only recording the lecture. It is right now 7 o'clock here in Portugal. And again, today we're going to talk about bleaching. So this is the second part of this Wednesday. Every Wednesday, if it is the first time you're watching this, every Wednesday. So we have 6 more. We have 1. This is the second one. We're going to have 6 more of this very quick, very fast. It's not even a lecture, it's going to be a talk about some challenging cases. Last week was composites. Today we're going to talk about whitening. Next week we're going to talk about bonding and finishing, a very challenging case. I'm going to show a little preview of what we're going to see next week. Last week when we talked at the end of the lecture, I asked you guys, many friends, many of you probably that were last time as well, about to send me, your challenging cases as well, so I could include. And I have some friends in Uruguay and they send me very nice cases. So this is gonna be the first time I'm gonna discuss those cases. They're brand new. Actually, I finished the lecture yesterday, so it's gonna be the first time. Thank you for the opportunity of sharing that. I hope you like. So let me, with no further ado, let me share my screen, the keynote presentation here. And remember one thing, I have the chat open here. So I have the chat open and we can talk through the chat. Of course, because there's a lot of people, I closed your microphone, guys, sorry about that. But please feel free to write me. I have the chat open. We can participate through the chat in order to have to exchange some ideas. So we talked again last week about restorative. Today we're going to talk about bleaching. Most of the cases are not even mine, and this is a good example. This is from a friend from Uruguay. Karin, if you guys never been to Uruguay, it is the best. I don't know how to, dulce de leche. It's made of milk. It's the best sweet you ever get. It is from Uruguay. This is a case from Uruguay, and this patient has kind of a long story. So to make it short, he was using the orthodontic appliance. He took the brackets by himself. And then he came to another dentist and he was complaining about the stains and what was possible to do about those things. So the first thing, and this lecture, this very quick lecture is going to be about that. Treatment depends on the diagnostics. So the first thing we need to do is to diagnostic, to make a proper diagnostic. So there's several things happening here. So can it be that bleaching might help? I am 100% sure, but not necessarily for everything that it is happening there. Bleaching, more than anything, bleaching will never get us to the color that we want. It's gonna get us to the color that it is possible, and it is only possible to do that much. Bleaching, again, it is the only 100% non-invasive static technique. So this is why it's so important, bleaching, but it is also important to know that it is not a miracle that we do. So let's see what it is happening here. The first thing that we can notice, have you noticed this, that he's probably a heavy bruxist? So this is the first thing, he is probably a heavy, there is no, the canine has no cusp, the lateral has been grinded. So he's probably a very heavy bruxist, and bruxism pays a very heavy toll on the dentition. So let's take a look what it is happening there. How many stains, different stains we have. Let's take a closer look. We have enamel loss in black. So there's enamel loss, literally there is no enamel there. This probably looks like caries. So it is hard to make a diagnosis. It's not my patient, it is a patient that Karen sent me the case from a dentist there in Uruguay. It seems that black line there, and I surrounded it in red, it seems like micro leakage, and probably it is, because if he took the orthodontic appliance, this is probably some micro leakage in the margin between the orthodontic cement and the tooth. So those are the things that bleaching is not meant to bleach that. In green, this Bleaching probably will do something on those stains in green. We can see that on the central incisor, that it is in the tooth. So it is internal, probably came from outside, but is into the tooth. So it is internal, it is not external. On the canine, it seems external. If it is external, we remove with prophylaxis. If it is internal, then bleaching will do that. Hey, but Rafael, it is too much. I know it is too much. Bleaching probably will help with that, and definitely will help with the overall color, but not those specific colors that I said. We can also see in yellow there that we have an inactive hypocalcification stain. How do I know it is inactive, that it is no harm? Because it is shiny. When a lesion is shiny, it is inactive already. So it is not a bigger, it could be a problem, it is not anymore, but it is important to deal with that as well. So it is important to do what? Diagnostic, to understand that there are several causes of discoloration here, and that each one of them deserves and requires a different treatment. So that is the thing. Bleaching will help, definitely, but first we need to take, if that is caries in blue, we have to take care of that. If in black it is enamel loss, bleaching is not fixing that. We need to do a composite. But in green, we can fix. How do we fix that thing in red there? By removing the orthodontic cement. And how do we fix the whitening spots? Probably by blending it with the tooth after bleaching, or we can also apply some fluoride in order to do that. So what I would recommend in that case, treating all active lesions. So this is the first thing, to provide health. Active lesions, if that is caries, we need to treat that. This is a beautiful discussion on how to do that. I don't want to go that deep, not in this lecture, but feel free, we can talk about that later through the chat or at the end of the lecture. If we should restore with composite or not because of the color change, because of the bleaching. So right now, the first thing is treat the active lesions. We can only do bleaching in a healthy environment. So treating the caries, treating the lesions, and then doing the bleaching. Then we're gonna see what else it is important to do. So I would use probably opalescence PF. It is a carbamide, it can be 10, 15, we're gonna talk about that. 20% depends on which country you are. But I would use with the tray. I would do a more long-term treatment in that case, and also take care about that bruxism there, okay? You can use also some enamelast. Enamelast is a very nice fluoride varnish that we can also use at the end of the bleaching process on those white spots and in order to bring a little bit more strength for the enamel. So good diagnostic. If you guys already saw my whitening lecture, you're gonna remember this slide. Good diagnostic is answering those very simple 3 little things. Why the tooth got dark? Sometimes, as I showed, there's several things that make that tooth got dark. In peroxides, they're good. So we need to understand that some stains, they're bleachable and some they're not with peroxide. So this is another thing. It is bleachable, and with peroxide, because that's what we have to bleach. Some of them are, some of them aren't. And the last one, it is how peroxides will affect the living structures, the living tissues beneath. And one of the tissues, definitely it is the pulp, but the other one, but the pulp tells you that, and this is the thing, the other one, it is the bone, and the other one is the periodontal ligament. It is also alive, and this one usually doesn't tell you nothing. So this is one of the things I want to talk today as well. So let's see another case. Oh, this is a nice case. This is a nice case. So this is another patient also from Uruguay. And after bleaching, it's a very nice result. We can see that it is wider than B1. So this is a bleach already. Patient and the doctor, they were complaining. I don't know if you can see. I'll try to show here in this region, in this incisal region here, that this grayish aspect that we can see, it's like a grayish bend here on incisal, both central incisors. So let's take a closer look here. So this region here, it looks wider. And why is that? After bleaching, this probably hasn't to do anything with bleaching. It is not the whitening process fault. This probably is the orientation of the prisms, of the animal prisms. So depending on how they are oriented, probably light travels better on that orientation there. Sometimes it changes. There are patients that this happens more in the middle third. This one is in the incisal third. But what is happening there, it is light. It is penetrating very good. And it is getting lost in the throat. It is getting lost in the deeper layers of the tooth. So less light is coming back. So there's nothing bleaching agents can do in that situation. So who can do that? Who can help us? What is the next thing that we can do? It's a little, I would not say invasive, but what we have to do there is like makeup, and women knows that very well. It's a little makeup we need to do. We need to opacify a little, not too much, but a little bit so light doesn't penetrate that much. How do we do that? In a very non-invasive way. We apply a denting, very thin. I'm gonna talk about that. I talked already last week. I'm gonna talk about that again next week and the following 2 weeks probably, but a very thin denting opaque layer. But it is so thin that it is not opaque anymore. This denting very opaque layer is not opaque anymore. It is kind of translucent, but gives me some white, so I can balance this too much translucency. If I balance too much, if I make too opaque, then I change from one problem to the other. So it is a little balance. Not that easy, but trust me, not that difficult as well. Only know that there is no point on trying to bleach more and more, because it is not a bleaching problem anymore. So this again comes down to diagnostic, okay? Awesome. This is a beautiful case from a friend, and this is the case that I got yesterday from Dr. Fabiana Rieta. And I remember when she's a doctor, she's becoming a respected doctor. She loves the profession. I remember when she got into the university, because she's the daughter of a very good friend, also in Uruguay. And this is a beautiful case. I forgot how long it's been, the history of the tooth, but I know it is more than 50 years. I think it is 56 years. So half a century, more than a half a century ago, there was a story of trauma. So this patient, now an elderly patient, he was a kid, he was just a boy. There was some trauma involved. I don't know specifically what kind of trauma it was, but it was a trauma. It was necessary to do the root canal. And after half a century, and we know the longer it takes for us to bleach, the harder it is to bleach, we get here that the tooth, it is incredibly dark. It is incredibly dark. So inside, so we have something that it is inside of the tooth, a stain that it is inside, a stain that came from the inside, because this is another thing, if you guys remember, who held the opportunity to saw my bleaching lecture. When we're doing bleaching, stains, they are inside of the tooth. Stains that came from the outside, they tend to be easier. Stains that came, the pigments that came from the inside, they're harder to bleach. So this one came from the inside. This one's for more than a half of a century there. And to make things a little bit more difficult, we have this as well. It was sealed 50 years ago with silver amalgam. So it is amalgam there. Silver is also responsible for that staining. Bleaching silver stain, it is very, very hard. And this case is being so the picture that we're gonna see right now, and that's the picture, this is only after one appointment, and this is from Monday. So Fabiana sent me this image. She sent me yesterday or the day before yesterday. So this was the procedure, the first and only application. And she chose to use opalescence endo, which is the strong material is 35 hydrogen peroxide. So she did one application of that, and I had the opportunity of talking to her during the weekend. And we agreed that probably the best technique here it is to combine. Start with a stronger material, with a more concentrated material, a material that will saturate the tooth faster with oxygen, and then we're gonna change. She's gonna change, but she's the responsible. She's gonna use a carbamide peroxide, because this kind of stain, half of a century old, endo and dental amalgam, this is hard one. This is a hard one to bleach. This requires patience. But what it is the reward after that much patience? We have usually, and now I'm talking by experience as well, something that bleaches better and something that bleaches for longer, so there's less rebound. So combining techniques, not only on vital bleaching, non-vital bleaching, usually it is a very good idea as well. We're talking about extremes. I don't want to go too deep in this, not in this lecture, my friend. There's another lecture, and definitely I had one, and I'm gonna have several other bleaching lectures. I don't want to go too scientific, because it's not the purpose of this lecture here. The purpose of this kind of Wednesdays that we have together is to make something lighter and everything. But remember that everything that comes from the outside and that it is inside of the tooth, usually easier to bleach. Everything that comes from the inside, usually it is harder to bleach. So Fabiana's case, it is definitely here. We have the post-eruptives, endodontic materials, and restorative materials because of the dental amalgam. So those are hard to bleach. And there's also a history of trauma in that tooth. So it is a hard one, and definitely a little patience with that. It will give Dr. Fabiana and also the patient a very good result. I'm sure of that, because of the first result already so good. Only a matter of patience and maintaining with carbamide 10%. We're only maintaining the levels that opalescence endo, with its hydrogen 35%, got us very fast. So that is the idea. It is to maintain that. That's a case. That's my case, so I wanted at least one case. There's three cases that I had, but this is a challenging case, way less than Fabiana. So this is also a good perspective, always helps. But that was a trauma also, and when there is trauma involved, what is the risk? We have a higher, I'm talking about trauma so many times, and why is that? Because there is no risk of sensitivity, or the risk of sensitivity is too low. It's too low because there is no pulp, but there's always what? Periodontal ligament and the bone crest as well. So what is the risk? When there is trauma, the risk of, we have an increased risk of bone resorption. Bone resorption usually is low and usually is silent. And what is the problem with bone resorption? It is that sometime after we do the bleaching, like 2, 3, 5 years, the tooth is lost. So this is the problem. This is also a patient, a heavy bruxist. If you guys can see here, is also a heavy bruxist. You can see that there is loss of the cusp here. There's no cusp anymore. And both central incisors and right upper lateral incisor, they were killed, let's say, by the bruxism. After root canal, 10 years passed, very dark. So we're talking about A4, A3 and a half. I did the bleaching. And I only used carbamide 10%. I haven't used the opalescence endo 35 hydrogen. I could have used, but I chose to use very, very low concept. Took me more time to do that. Took me like 5, 6 appointments, changing every week, changing the gel inside. But got me a very good result, long lasting. That's been 8 to probably 9 years already. And the result is stable and a very good result. I'm very happy with that result. This is something I would like to share. I would like to thank a good friend, Dr. Cassio, for lending me those images of he's an endodontist, and I got those images from from his lecture. And the thing is, I want to share how do I do the preparation inside of the root to get the bleaching agent safely in there. So everybody knows you did the end or someone did for you. So we have endodontic treatment there. We have gutta percha there. Where should we cut gutta percha? I personally like to cut gutta percha 1 millimeter below gingival line. There's several techniques that says that you have to crest 1 millimeter below the bone crest, that you have to cut below the cementum enamel junction, the CAJ. I prefer, I see where the buccal line goes, and I cut 1 millimeter below that. So probably it's 1 millimeter below the gingival line that I see in buccal, because this is another thing. Where is the gingival line? In buccal is one side, and when we have the proximals is another one. So here in buccal, I will cut 1 millimeter below gingival line. That's what I do. That 1 millimeter that I have is there where I'm gonna apply my glass ionomer. Glass ionomer, there's some studies about that. It is kind of an annoying material to handle, you know, the glass and powder, but it is still the best one to seal that, you know, to seal the leakage of peroxides into the periodontal ligament through dent and cementum. It is still powder and liquid glass ionomers. There's very good materials that is easier to handle, but I really like glass powder, classic glass ionomer. Okay, so I cut it. I don't know if you guys noticed, but let me come back here. Have you noticed that when I cut gutta percha 1 millimeter below gingival line, when I'm looking through proximals, I am already on the bone crest. And why is that? Because in the proximals, bone crest, the height of the bone is not circular. It is not the same one around the tooth. I have more bone on proximal. On a healthy tooth, I have more bone on proximals. So I might not be under the bone level on buccal, but definitely on proximals I am. So this is when this technique comes very handy, because I'm gonna apply glass ionomer, but I don't apply only a plug. What I do, and I learned from a good friend, I wanna share his name as well. I express glass ionomer all over the endodontic aperture, so the endodontic access. So the whole cavity I'm gonna fill with glass ionomer. Then with a very thin spatula, I'm gonna save 1 millimeter from buccal, and I'm gonna remove the rest only on the buccal wall. Proximal wall and palatal wall, they will stay with the glass ionomer. Only from the buccal, I'm gonna remove. So that's what I do. It's a little ramp. I save 1 millimeter in buccal, and I leave glass ionomer on the proximals and on the palatal as well. And the palatal becomes like a ramp. And I have 1 millimeter here. And I have protection all over the other sides. The palatal I have protections, and proximals I have protections. I have protection also apical, because I have still my 1 millimeter here. So this becomes a little ramp. Then I can express my material, my bleaching agent, whatever bleaching agent you chose. You use a little paper membrane. You can do a cotton pellet if you wish as well. And then you seal the entrance of the access, the endodontic access, with some provisional material until you do that next time. If you're using opalescence endo every 2 days, and you need some days also awaiting, if you're using carbamide peroxide, you can do that every other week. Okay, so this is a technique that a very good friend, he's also an endodontist, Dr. Renato Miotopalo, living in the US right now, and he taught me that technique, very good technique, and I want to share his technique with you guys. So you can, again, choose to use depending on the kind of bleaching you're doing. So walking bleach technique, you leave the material inside. So this is only a list of everything that I said. I prefer using glass ionomer, 1 to 2 millimeter thick. So it depends, it's not homogeneous the way I do. You put the bleaching material there, cotton pellet or a paper membrane if you want, apply material, and then you do. Okay, another option is that you can do also in office. So you can do, that's 1, 2, 3 applications in office. You apply the material, you remove the material, and the patient goes home without the material. Also very good results. And the idea here, again, it is to saturate the tooth with lots of peroxides, with the oxygen reactive species from the peroxides. We're going to do that faster than we would do with a regular walking bleach technique with a weaker material. Okay. Again, Dr. Fabiana Rieta with a beautiful, and she sent me this picture, said, I don't know if it is too challenging. I think it is. I think it is. Why is that? It's an older patient. We have an endodontic treated tooth here, and that's what she did first. It did, I guess it was a walking bleach. I have to check with her, but she did a walking bleach, got very good results with the walking bleach, and then she bleached everybody. Look how beautiful it is, the result that she got. Very, for me, it's very challenging, this kind of case. Very challenging, very beautiful case. I like, what is challenging here? We have 2 different kinds of bleaching procedures to do. What it is beautiful about that, 100% non-invasive and very beautiful results. Like that case, I liked that case very much. So the before and the after. It's a very nice case. And there are several ways we can bleach as well. When we're talking about trays, it's not only the custom trays that we have to do on the vacuum form, we can use also the Opalescence Go. My experience, my opinion, it is that nowadays it's one of the best methods, fast, reliable. I like it very much. Depending on which country you are, it might be hydrogen 6% or 10% or 15% or both. So it depends on which portion of the planet you are. In Brazil, we have 10%, in US 10 and 15, I know here in Europe 6%. This is also my case. So there's only 2 more cases and we're gonna finish. This is also my case, very simple case, very simple, it's not challenging, so I said challenging cases. It is only to say that, you know, most of our cases, we don't need anything special. So that was an A3 and I used carbamide 10. I just want to talk about that, which concentration to use. Carbamide 10% we use in this case from A3 to B1, so a very, let's say the before and after, very nice result. Took me like 2 weeks to do that. So which is the best concentration? Actually, the best concentration doesn't relate to how much wider it will be. It relates to how fast you're gonna do. So this is the thing. You can do anything with 10% if you want. It only takes more time. You can do a little faster. So it's literally like driving. If you go 50 kilometers per hour, takes two times more than if you go 100 kilometers per hour. But if you go 100 kilometers per hour, there's also might be, also depends on which kind of road you are driving, there's more risks of accidents. So if it is a road, there's no big deal. If it is a city street, you probably don't want to go that fast. So this is the thing, it is understanding where you're driving, what kind of bleaching you're doing, and what are the risks involved in that bleaching, only after a good diagnostic, okay? So another case, this is a wonderful patient, and she's a 3.5. And with her, instead of using 10%, I used 15%. It's the same B1. So at the end, when we bleached, it's the same B1 as the case before, but only took me a little faster to do that. So that's the difference. Also, you can do what? Instead of using 8 hours or 6 hours, the trays, you can use for a little less time also. So the concentrations are more for adapting to the patient's lifestyle and also to how fast we want to go on the bleaching. Okay, so how much time patient was going to use the trays and for how long the treatment is going to be. So that's why we have so many concentrations to choose from. Only remember that higher concentration doesn't mean wider teeth, okay? And this is the final result, a 3.5 to B1 as well, only a little faster. Perfect, my friends. Respecting the time, really, I'm shocked that it is exactly 30 minutes of lecture. I haven't tried this lecture before, so it's good to know it's only half an hour. This is what we're gonna talk about next week. We're gonna talk about etching and bonding. And why is that? Because this was a very challenging case. It's so challenging that I finished that case last year. Last year, this case became a book chapter as well. So it is already being published as a book chapter. And why is that? This is a rehabilitation patient that we need to increase a lot the vertical dimension. And the idea was to do that. It was a mixture of composites on interiors and ceramics and other kinds of material, and direct on interiors and indirect on posteriors. Then you ask, why direct on interiors? Because it was less invasive. Very beautiful, very successful case. But also, I'm gonna tell you one thing, very challenging case, because it is very high, and it is only bonded. So next week, we're gonna talk about bonding and finishing as well, how to do proper finishing. It's some tips that I would love if someone taught that to me 20 years ago when I was newly graduated. So that's what I wanna share next week. We're gonna talk about that case. I wanna speak a little bit about bonding, how to get proper bonding, how to do a good finishing, okay? My friends, once again, thank you very much for the time, for this half an hour that we spent together. You guys have my email, so again, feel free. I know that the whitening lecture just been. Feel free, please. You know, who already wrote me knows that. You can send me anything. You can send jokes, you can send the cases, we can discuss cases, we can exchange ideas. So if you have any challenging case, please feel free to share and to make questions. And also right now, I would like to invite you guys to, if there's any doubt, anything that I spoke, I know it is a quick lecture. If there's anything that I spoke, it was a little fast, feel free to ask through the chat. The chat is open. And thank you, Beata. Thank you so much. Anya, thank you. We are all the best. It's not only me. You guys are better than I am because you're still here. Dornwell, thank you guys also, my friends from Poland. Agatha, thank you so much as well. Marta as well. If there's anything, please let me know. And if there's no questions, I think I will only, you know what I'm gonna do? I'm gonna only stop sharing here my Is it still sharing or not?